Good morning. I am Dr. Teke Apalata, a specialist in clinical microbiology. And today we are going to discuss sepsis and septic shock. This lecture will be conducted in two parts. And let me just try to share my screen with you to start with the first part of this lecture. During the first part of this lecture, we will on bacterial sepsis and septic shock. We will try to understand the definitions of key concepts and the diagnostic criteria. And we will also discuss the causative pathogens, the pathogens that are commonly associated with sepsis and septic shock. As I said, I am Dr. Teke Apalata. I'm a consultant in clinical microbiology. So, what are the terms that we are going to define? What we need to understand? First, we need to understand what we call systemic inflammatory response syndrome. Systemic inflammatory response syndrome. We will understand the concept of sepsis and the septic shock. So you will see that I scratched the concept severe sepsis because we normally use the term severe sepsis. It's sepsis or septic shock, and we have multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome. So those are the four concepts that we will try to understand. Now, what is systemic inflammatory response syndrome? We define systemic inflammatory response syndrome if we have two or more of the following four criteria. Now, one is that someone should have a temperature of above 38 degrees or below 36, heart rate of above 90 beats per minute, and the respiratory rate of above 20 per minute, or you can do it by measuring the partial pressure of CO2 that should be below 32. And the fourth element that you can look is white blood cells count that can be either above 12,000 per cubic millimeter or below 4,000. So when you have two or more out of those four criteria, you can say that you can make a conclusion of a systemic inflammatory response syndrome. You can say that your patient has a systemic inflammatory response syndrome. But now, what can cause a systemic inflammatory response syndrome? It's not always an infection. So you will see that there are also other causes of systemic inflammatory response syndrome, like a trauma can cause that. Patient with burns can develop a systemic inflammatory response syndrome, pancreatitis. And another portion that is caused by microorganisms that can be bacteria, fungi, viruses, or parasites. So the infection and predominantly bacteria are the main causes of systemic inflammatory response syndrome, bacteria that can cause systemic inflammatory response syndrome. So what I'm trying to say is, if your patient meets the criteria for systemic inflammatory response syndrome and the causative, and you found that there is a microorganism that is causing the problem, so you call it sepsis. This is actually the original definition of sepsis. So sepsis means your patient meets the definition of systemic inflammatory response syndrome, plus the causative agent. You confirm the presence of a microorganism as the causative agent, as the causative pathogen or agent for systemic inflammatory response syndrome. So that is what we call sepsis initially. But this definition of sepsis has changed since. It has been an underestimation of what we call sepsis. So using systemic inflammatory response descriptors to define sepsis has been an underestimation. So sepsis could be much more than that, because sepsis does not only rely on those changes, but there are also immunological changes that can be detected much more earlier, because there is an early activation of pro and anti-inflammatory responses. In addition to that, sepsis involves organ dysfunction, and those that are commonly involved are cardiovascular dysfunction, neuronal, autonomic, hormonal, bioenergetic, metabolic, coagulation dysfunction. So those dysfunctions are associated with sepsis. So not using them in the definition of sepsis could be a challenge. So as a result, we have new definitions for sepsis. Sepsis is defined as a life-threatening organ dysfunction that is caused by a dysregulated host response to an infection. So what it means is that you need to have an infection as an underlying reason for the organ dysfunction. And the dysfunction, you can then look at different organs to see which one has been challenged or has been in a problem, you know. So then we use a score, what we call a SOFA score, you know, to assess the level of organ dysfunction. So SOFA score, SOFA means only sequential or sepsis-related organ failure assessment score. That's what we call SOFA, sequential or sepsis-related organ failure assessment score. And a SOFA score, a baseline SOFA score in the absence of organ dysfunction is considered as 0. Now, if the SOFA score starts increasing, then it becomes a problem. It means that you are undergoing organ dysfunction. Then from a SOFA score of 2 and above, the prognosis of this patient recovering from this infection is decreasing. So it means that from 2, almost 10% of hospital admitted patients are high likely to succumb from their infection. So the SOFA score is diagnostic, but it's also prognostic. It has a diagnostic value. It also has a prognostic value. So here we look at respiratory markers like your partial pressure of oxygen, that you can see that in baseline it is very high. You know, it's 400 and above. Then when this starts decreasing, the partial pressure of oxygen starts decreasing, the SOFA score is increasing. And when it's from 2, you know, when it's from 2, here it means that it's below 300. So there is a dysfunction that is clearly established in terms of respiratory factors. We also look at coagulation markers like platelet level. You know, platelet level that are high, usually from 150,000 and above, and start decreasing when the SOFA score is increasing. We have the liver marker like the bilirubin levels, you know, that starts increasing. We have cardiovascular markers. We measure the mean arterial pressure. So if the mean arterial pressure is decreasing, or if you can sustain a high and acceptable mean arterial pressure only by using medication like vasopressors, then it is a problem. So there is a clear dysfunction. And we have also CNS, and it's measured by a Glasgow Coma scale that is decreasing. And we have renal function that is measured by creatinine. So you will see that the creatinine level starts rising. And we have also the urine output that is also decreasing. Now, if what we are saying is that if you have a SOFA score of 2 and above, you know, that is an indication of organ dysfunction in the presence of an isolated causative pathogens that is associated with the infection. Then you make the definition of sepsis. That is what we call sepsis. So sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. Now, in the clinical setting, we can use what we call a quick SOFA, you know, to have an idea of whether or not we are dealing with a sepsis. So a quick SOFA look at 3 things. You look at the respiratory rate that is from 22 above per minute. You have a alteration of the mental status of the patient, you know, by GCS that is decreasing, and you have a systolic blood pressure that is 100 and above, you know, a systolic blood pressure from 100. So when you look at those 3 elements, you know, the patient with suspected infection who are likely to have a prolonged ICU stay or die in the hospital can be promptly identified at the bedside with quick SOFA. When we have alteration in mental status, systolic blood pressure that is 100 or above, and the respiratory rate of 22 and above per minute. So it gives you a quick indication. Now, what do we call septic shock? After understanding sepsis, now what is septic shock? Now, septic shock is a subset of sepsis. Now, there are a group of patients diagnosed with sepsis who will now progress to a septic shock. So there are 2 things that you will look. When the patient meets the definition of sepsis or the criteria for defining sepsis, and those patients then have a persistent hypotension requiring vasopressors to maintain their mean arterial pressure from 65 and above, and also having a serum lactate level of more than 2 millimole per liter or 18 milligram per deciliter, despite adequate fluid resuscitation. So this is what we call septic shock, you know. So septic shock is first the patient meets the definition of sepsis, and you realize that despite the use of vasopressors, those patients are constantly having hypotension, and also you check their serum lactate level, it's constantly above 2 millimole per liter or 18 milligram per deciliter. Remember, we say that there is organ dysfunction. We also have either immunological changes or metabolic changes or cellular changes during sepsis. So during septic shock, the lactate level is above 2 millimole per liter. And the mean arterial pressure can only be maintained when you have vasopressors. If you withdraw the use of vasopressors, the mean arterial pressure will automatically drop. So this is what we call septic shock. So you have a patient with, in summary, you have a patient with suspected infection. You have a patient here with suspected infection. You do a quick SOFA. If it's 2 or above, you know, then this is an evidence of organ dysfunction. Then you have an evidence of organ dysfunction. You want to know, this is meeting the definition of sepsis. Quick SOFA, you check respiratory rate, mental status, systolic blood pressure. And is it meeting the definition of sepsis? You look any of these organ elements to establish that there is organ dysfunction. If yes, then the patient has sepsis. Now you start resuscitating this patient because the management of sepsis involves two things: strong resuscitation and source control. So you start resuscitating this patient, you give fluid, more fluid, but despite adequate fluid, despite that the serum lactate level remain above 2, and you put this patient on vasopressor, then the mean arterial pressure is also dropping if you don't use vasopressors. Then if you only rely on vasopressors to keep an acceptable mean arterial pressure, and you have a constant serum lactate above 2, then this patient has a septic shock. Now, what are the common causative microorganisms? Now, initially, before the introduction of antibiotics, gram-positive bacteria were the commonest causes of sepsis. But then subsequently, with the antibiotic use, gram-negative became more common. But currently, we observe again that, with the use of invasive procedures, especially in critically ill patients, both gram-positive and gram-negative bacteria are commonly found to cause sepsis and septic shock. Now, what is the difference between gram-positive and gram-negative? And there is always an impression that gram-negative are the commonest causes of septic shock, and I will say why. Now, the difference between gram-positive and gram-negative is from the structure, of their cell wall. Now, here you have what we call, this is a structure of a gram-positive. You see that from the inside, we have what we call a plasma membrane. That's what a gram-negative also has. This is a plasma membrane. After a plasma membrane, you have a periplasmic space. Then in gram-positive, you have a very thick layer of peptidoglycan, a very thick peptidoglycan layer. But in gram-negative, you have a very thin peptidoglycan layer. Thin here, thick peptidoglycan layer. And this thick peptidoglycan layer help gram-positive surviving environmental conditions in the hospital setting. But now, what makes gram-negative much more dangerous is the fact that beside this thin peptidoglycan layer, you have another periplasmic space, then you have an outer membrane. Now, this outer membrane contains lipopolysaccharide and proteins. So this is a toxin, an endotoxin. This is an endotoxin. So a patient who is infected with gram-negative will have, during replication of the gram-negative, there will be this endotoxin that will be released. And that will make most of those patients progress very fast into developing septic shock. So if you have to look for the source of this infection to control it, most of the studies have shown that the commonest infection that is associated with sepsis and septic shock is actually lower respiratory tract infection in the range of 35 to 50%. So you can suspect chest infection. When you are screening a patient with sepsis or septic shock, you have to look at the focus and you need to think of a chest infection. And the pathogen can be your gram-positive like streptococcal pneumonia or your gram-negative like Klebsiella pneumonia. It also depends whether you are looking at community-acquired versus hospital-acquired infection. If the patient is coming from home with this suspected infection and you have to think of a gram-positive, it can be streptococcal pneumonia. It can be Haemophilus influenza, for example. But from the hospital setting, it's high likely to be a gram-negative, and you have Klebsiella pneumonia, you have E. coli. You also have a typical pneumonia that can be caused by Legionella species. And a serious gram-positive infection can be Staphylococcus aureus, and gram-negative, you have Pseudomonas and anaerobes. Now, beside the chest infection, you can also think of abdominal or GIT infection, gastrointestinal infections. And here you can think of E. coli, or Enterococcus species, Bacteroid, Acinetobacter, Pseudomonas, Enterobacter, Salmonella, and Klebsiella. So you can think of causes of abdominal infection, especially if the patient was in theater for abdominal surgery, came back to the ward and developed sepsis. You check that the wound is clean. It might be that there is an abdominal infection, an underlying abdominal infection, and you need to think of commonest pathogen. The reason you need to remember those commonest pathogen is because you have, after collecting blood for cultures, you need to start your patient on empirical treatment. Then you need to know the high likely causative agents that you want to cover. So you think of lower respiratory tract infection, then on the second position, you think of abdominal infection. Then you can also suspect urinary tract infection, and the commonest causes can be your E. coli, Proteus species, and Klebsiella. And if the patient maybe is catheterized, you can think of other causes like your Pseudomonas, Enterobacter, Serratia, Enterococcus, and even Candida species. You can also suspect soft tissue infection, especially patients who are coming out of theater a few days after that, you can have soft tissue infections. And the commonest causative pathogen can be Staphylococcus aureus. And anaerobic bacteria can also cause that. Then very unlikely or uncommon causes, but they can be there, can be infection of either male or female reproductive system. So you can think of other causes, but you also need to think of STD pathogen, like Neisseria gonorrhea. You can also have serious infection with chlamydia or Trichomonas vaginalis that can be involved in PID, pelvic inflammatory disease, in female patients that can lead to sepsis and septic shock. But it's less likely. It's not as common as what we have mentioned. So with this, we have discussed the definitions of key concepts. We have understood the diagnostic criteria for sepsis and septic shock, and we reviewed the causative pathogen for sepsis and septic shock. Now, in part 2, we will discuss the pathogenesis, and we will also discuss the management of those cases. Thank you.